Dear colleagues, hi everyone. I hope you are well. Welcome to the third webinar, of our EuroPref e-learning program from 2023. I'm very happy to say and to share with you that this webinar is a result of a very, sorry. Oops, okay. There was a feedback. But I was saying that I'm very happy to share with you that this specific and very special webinar is the result of a positive partnership, a partnership from EuroPref with EQUIP. EQUIP is the Wonka Europe network for quality and patient safety. So, and here with us, we have the president of EQUIP, André Rochefort. André, welcome. I'm very happy to have you with us. And how are you?
Thank you very much, Carlos. Yes, indeed. And thank you for your kind words. And we spoke about doing a joint webinar like this sometime during 2022, probably at the Wonka Europe conference. So it's great that we have achieved it now.
Yes, it's really. And André, today we are going to talk about lifestyle interventions, and we have a special guest. Do you want to present him?
Yes, I'm really proud and delighted that Johan Haynes, Dr. Johan Haynes from Belgium, has joined us. And Johan, I would like you to follow on and introduce yourself, please, but you are an expert in lifestyle medicine. You are the vice president of the European Lifestyle Medicine Organization, and you are the coordinator and tutor on the wonderful certificate course. And that's how I met you, because I did the certificate in lifestyle medicine with the European Lifestyle Medicine Organization end of 2021, the last few months of 2021. Which I really enjoyed. And it's wonderful to bring you here, and thank you for joining us, because it's almost like it's a lovely merging, a lovely merging of prevention and health promotion and quality of care and safe care and lifestyle medicine. I think it's a really nice combination.
Thank you very much for the invitation, and nice to meet you, Carlos. Andrea, I had the pleasure to meet in the certificate. Then she got involved in the European Lifestyle Medicine Organization, and I think such a webinar maybe 3-4 years ago was not even possible to imagine. So this is why I'm happy that today we can chat here, discuss, and to see what is exactly lifestyle and how this can be integrated through behavior, especially in medicine. So thank you for sharing your time with me here.
Thank you very much. Thank you both. And Johan, where are you doing this webinar from tonight?
So I'm in Brussels, in Belgium. I'm, as Andre said, I'm a medical doctor working half-time in a military hospital. So where I help militaries, soldiers, to lose weight through lifestyle interventions. And then I also have some medical expertise. And then outside of my full-time work, I'm really passionate about lifestyle medicine. So this is why the case is what we present here. It's from my own practice. And
okay, thank you. And André, are you making this webinar from Dublin?
No, I'm not. I'm 100 kilometers directly south of the Irish College of General Practitioners, actually.
Okay.
In my home in the southeast of Ireland, where we've had a lot of rain all day today. It's in the countryside, in a rural area, and where I practice is 15 minutes drive, slightly north,
Okay.
close
Okay.
to the sea.
Okay, I'm doing this webinar from Porto, Portugal, and take attention, Andre and Johan. Hassan Kabir, hello from Bangladesh. Good evening.
Wonderful.
Yolita Trakowskiene, greetings from Lithuania. Nice to see you again. Hi, Yolita, thank you. And I'm sorry if I don't pronounce your name correctly. Marta Gaza Tarando, hello from Dublin. Happy to attend the webinar. Adriana Dogaru, hello from Romania. Maria Bacola, hello from Ioannina, Greece. Xenia, good evening from Slovakia. Filipa Santos, boa noite, good evening in Portuguese. Marta Tunzeva, hello from Skopje, Macedonia. Rosário Falanga, hello from Italy. Ana Mateus, hello everyone, greetings from Porto, Portugal. Jan, greetings from Czech. Lucas, hello from Krakow. I am happy to hear you. Francisco Guilhem, hello from Madrid. Paco Camarelles. And Mariana Leitão, good evening. So, I believe we are almost ready. Dear colleagues, your participation will be as in every webinar very important. So please feel free to share your comments in the chat platform that you have below the video player. And your comments and questions are very welcome, and I will try to share your comments and questions with our speakers tonight. And also we will have an attendance check for those of you that want a certificate at the end of our e-learning program. And we also have some televoting questions, and I will share the link so that you can access the televote page here in the chat. And Johan, I believe we can start, so you may share your screening. Let's do it. Let's go.
Thank you. So when Andrea told me about this evening, and we had the invitation from Carlos, we tried to see how we can share some practical approach, practical skills to make a bit different the work, especially with chronic patients. And as we know, our time it's limited, sometimes because of our own schedule, sometimes because the patient is used to say very shortly information. So this is why together with Andre here, we tried to build up some first knowledge about what is this lifestyle medicine, what exactly we mean by lifestyle intervention, because this is very different for us like health practitioners, but it's also very different and very general, especially for our patients. And then, as I mentioned at the beginning, lifestyle enters in medicine through behavior. So this is why I think there are 82 types, methods of changing behavior. So as you can imagine, in a very short time, we cannot do all of this. So I insist on those, on that which is mostly practice, listing lifestyle medicine, the motivation interviewing, and probably most of you are familiar. So I will just give some skills, and then we will try to see together with Andre what means self-care, how we can do self-care, because that is something what we practice in lifestyle medicine, how we can find time and how we can do self-care with ourselves, so having a healthier lifestyle. Now, as I mentioned, we met in the European Lifestyle Medicine Organization board, where I was very happy that Ireland was represented by 2 persons out of 5. So we really try to build up many interesting projects in the future. and especially to integrate in general practice related to chronic disease, the lifestyle interventions. Now, this what you see here, I even think that it's not yet on the website of Elmo, so but will be there. So it's we have a scientific council which decided recently to define lifestyle medicine. Now, you have also to know a bit for the history, which is also important, also even in medicine, that this movement started in US, so they really are a few steps, a bit more steps ahead of us. But we tried here through this definition, to give the European touch of what means lifestyle and lifestyle in medicine. So very shortly, it's an evidence-based branch. So we don't do voodoo, we don't do other type of things, we do medicine. That means for us that we recommend actually interventions which are based on guidelines, which has a solid solid scientific background. I'm just giving you an example: Mediterranean diet, where we have thousands of articles which support that approach in nutrition. So we talk about chronic disease. We through lifestyle intervention as a first line, we try to prevent, treat, sometimes reverse chronic disease. I have a dog here in the neighbor, so he agrees when you hear him barking, so I apologize. And then we really try to empower the patient. So the patient is someone who takes an active part in the consultation. And we will see how we do, because it is sometimes challenging for us, especially that we've been trained and we have this writing reflex, which I want to help, I'm telling you what to do. But when it's about behavior, we have to let first the patient to reflect. And that can happen even if, for 1-2 minutes maximum. And then we check also the health literacy. So as you probably know, today, half of the patient, they have no idea what the health professional is talking about. So we try to integrate this. And we are not against medication, but first line, it's when it's possible to do lifestyle intervention. Now, lifestyle, it's, as you probably know, it's about nutrition. It's about how much we move. So we don't use sport, because many people, especially chronic disease, are a bit reticent to sport. How physical activity, managing stress, sexual health and fertility, so that it's very specific for the European lifestyle medicine. Then sleep hygiene, social connection, and then environment and substance use, trying to minimize those which are harmful for the health. So I don't know, Andre, if I forgot something, or you would like to add something to this, because you've been an active part of contributing.
No, I think we've, as you say, this new European definition has been brought together by consensus by the board and the council of the European Lifestyle Medicine Organization, and we took some time to think it through. So it's very fresh and very new and very interesting.
Thank you.
I have a comment or a question. Should we talk about lifestyles interventions in medicine or about lifestyle medicine?
It's a very tricky and good question. So
I don't know if you have discussed it in your forum.
Well, I
in
think
medicine,
the core.
sorry,
go on.
Please.
The core theme of today's webinar is behavior changes. So yes, well, it's lifestyle medicine is an evidence-based scientific branch of medicine, but it doesn't sit just as a concept. It is the whole point of a medical doctor practicing lifestyle medicine is to help the patient make some improvement. So yes, it involves an intervention, but not as in the doctor doing an intervention for the patient or to the patient. It's very much shared decision making, and the patient decides what their priority is. It may not be the same priority as the doctor. So
Okay.
I think, Johan, I'm sure you'll expand on that concept, because that was very much key in the certificate course.
I would also like to underline something you said. You mentioned that it is evidence-based. And this is very important for us colleagues in primary healthcare and in family medicine, because this is a field, lifestyle related, that very often our patients, they get many approaches from non-evidence-based, from other movements, from pseudoscience movements. And it's important to emphasize this, that when we propose certain changes, certain behavior changes to our patients, our proposals are evidence-based and science-based. So I wish to underline that.
Yes, thank you for saying this. And actually, if you look the guidelines in diabetes, in hyperlipidemia, in hypertension, you will always have least, and luckily, least 1/4 or 20% of the guideline lifestyle interventions. Now, what sometimes scare us or stop us, it's because in medical school, we don't have trainings or not enough training, for example, in nutrition. So there were some studies a few years ago showing that only 25% of the medical schools in Europe, they offer practical nutrition skills during the 6 or 7 years. So it's very difficult to teach, to lead your patient like a young doctor if you have not been trained in nutrition, for example. But what is maybe also a bit to put in a context is, I mean, how I arrived here. It's a few years ago, 6, 7 years ago, or maybe more. I was facing patients the same type. So coming there, bad blood results, no changing in the habits. So I got frustrated. I said, something has to be wrong. I mean, I'm saying all the time, you should do this, this, this. And I was even doing a training in nutrition. And then we just see each other after a few weeks and nothing changed. So I was really, really frustrated. And I remember I was going on Google, I think, or something. I said, okay, what is lifestyle and medicine? And then I entered in this field. And what is also important to say is that traditional medicine, it's very good in acute care. It's very good. We have technology, we have the best interventions. But what changed today in medicine is that all what is mostly was infection-oriented virus, bacteria, and so on. Now we have good medication, we have treatments, vaccines, and etc. But we have totally another lifestyle today than we had 50 or 100 years ago. So this is why we are coming today with this approach, which tries to understand the patient in front of us. So in moment when I realize that the patient in front of me, actually, he's an expert. He's an expert about her lifestyle. So I have to listen first what's going on in the patient's lifestyle, and then trying to come with my knowledge, adapted, so personalized to his lifestyle.
Okay, let's go on.
So that was a bit the story about that.
Thank you.
Now, as you see here, it's a very recent data showing that today almost, 3/4 of the worldwide disease are caused by lifestyle choices. So again, we have data supporting what we try to change. and this situation will not change very, very soon. So as you can see, what it's foreseen for 2030. So I understood that we do here practical things. So I'm trying, based on our little taste, a bit of apéro, as we say here, to see how would you react to this case. So the real cases are from my practice, with the name changed, of course. So I had recently a patient, Akim, let's call him Akim, who is 47 years old, and he came for his regular control for type 2 diabetes. And he has this mostly lifestyle-related chronic disease since 2018. His hemoglobin A1C was 8.4%, which not much decreased compared with 6 months ago. His treatment, it's a bit the usual one with rapid-acting, long-acting insulin and metformin. And then looking at him and looking also to the BMI, he's overweight. I measured his blood pressure, which is very unstable. So at that moment was high, and he told me that sometimes at home it's normal, but it's most of the time unstable. And then the blood test showed also an high total cholesterol and high LDL, but he takes medication for that.
And now we have the first televoting questions, dear colleagues.
Exactly.
I already shared the link where you can access the televoting webpage, and I advise you to keep that link and that webpage open during the webinar, because whenever we have another televoting question, it will update automatically so that you can participate and answer to these televoting questions. So we have this case, this patient, and how will you approach him? Adapting his medication because I don't have much time, or asking him about his medication compliance as he probably does not take it correctly, or interviewing him about his lifestyle related to his chronic diseases if I have more time. So, Johan and Andre, it seems that most of our colleagues answered C, interviewing him about his lifestyle related to his chronic disease if I have more time. What do you think about this answer?
It seems that we maybe don't have to do this webinar because, I mean, participants are already familiarized with lifestyle medicine. So, or we are just good in convincing about the importance, or probably I think is the third option that we all here face that reality that how lifestyle interventions influence our patients. Now,
you have to share again your screening. I'm sorry. Yes.
So now what happened in 20 minutes, I didn't have much time there. I saw on his face that he was frustrated, that he was a bit not looking in your eyes. So he didn't felt comfortable again, nothing changed. So this is why I said, okay, I will go on the C option. So I asked him, I said to him that, look, I know that half of the patients who they have to take everyday medications, they just forget something sometimes, or they are just fed up with this. Is the case for you as well? And he told me, yes. Look, I'm not taking the long, rapid-acting insulin in the evening. I said, why not? I know, because once I did it and I had I felt that I will die because my sugar was almost 50, and then it was horrible. I said, but did you know that you can adapt? Oh, I didn't know. So, okay. Oh, that was probably very, very bad experience for you. And what else you know about how you can manage your diabetes without medication. Tell me, I'm a truck driver, so my food, it's not the best. Okay. What about physical activity? I suppose you don't have much opportunities since you are in driving old. No. And he was very proud about this. No. I wanted to be more with my family. So now I'm coming home. I do short distances, so I'm able to be more home. And in the weekend, I am doing some cycling and running. Okay, I was looking a bit outside on the window, and as you know, probably in Belgium, it's mostly raining. So I said, "Oof!" And what you do when it's raining outside? Yeah, he said, "Look, yeah, you are right." So was then a silence, 20, 30 seconds. And usually we will see a bit later that this is the moment when we invite the patient to reflect. So I changed the discussion. I told him, okay, just for you that you are informed. And then I look at the blood pressure. I said, being more active physically regularly could influence also in good your blood pressure. Okay, I didn't know. And then I was ready to close the consultation because I didn't have more than 15, 20 minutes. And he just spontaneously told me, look, but I have also an apartment bike home. And I can do that 1 or 2 times per week home this. And you will not be tired. Look, yes, but I really want to do something for myself with this. Oh, great. So I will write down, and I'm curious next time, how was your experience with that? 20 minutes. So yes, you choose correctly because it can lead to own initiative, the patient own initiative in this.
Johan, and if you didn't have time?
If I would not have time, I would ask, okay, look, you are here for your yearly control. What is your biggest problem today? What do you want us to talk about?
Okay.
It's very short, it's very powerful, simple question. And usually they say, most of the patients, I have pain or that, but I try always a bit to direct to lifestyle. But okay, you have the pain. I understand it's not very easy, but something about your life, what's going on there, and can have an impact on your medical condition.
Okay, because really time is an issue in our clinical practice, as you are aware. So sometimes many colleagues they feel that lifestyle interventions take a lot of time to talk with patients, and so sometimes physicians don't apply it or don't make lifestyle interventions because they feel they don't have time for it. Do you have any tips, any tricks to suggest to our colleagues, Andre, Johan?
I would certainly, what we have seen in the consultation as it developed there was that the patient was allowed to set the agenda. Because if you look at someone like Akeem here, he has several issues, and our temptation is to jump in and try and problem solve for all of those issues. And, say you need to change your diet, you need to exercise, you need to be less sedentary, you need to make sure you take your statin, and so on. When in actual fact, that's first of all overloading the patient with unrealistic tasks, because nobody can do that all at one go. So sometimes it's good to perhaps use an open-ended question like, where do you feel that you could improve your health or improve your lifestyle, which would improve your health in some way, and which way would you do it? And maybe then it would be cycling on the bike, the indoor bicycle, or maybe he would suggest something else. So you're getting them to come up with realistic, doable activities, a different way of approaching, which might not be the one we think about.
Exactly. When you ask the patient, sometimes, I mean, I'm working mostly with a patient who wants to lose weight, overweight or obese, and I ask them always that, look, why do you want to lose weight? And say, yeah, but for my health. Okay, but what is for you your health? I know, actually, no, I want to fit my old clothes. You will never, but this kind of motivation, be a motivation. But coming back to what Andre was saying, when you ask this, okay, what is your biggest problem today? How can I help? It's focusing. It's already from all the factors, you are focusing on one. And then it's not taking more than 5 or 10 minutes. I invite you to try, or list what was saying Andre, to pose open-ended questions. So those questions that will not reply with yes or no with one word. So in this case of Hakim, what do you think about your value?
Okay, thank you.
And sorry, Carlos, using the word biggest problem is really useful because, as you know, in general practice, people often come in with a shopping list and they go through problem 1, 2, 3, and then they say, we are getting uneasy and it's coming to the close of the time. And then they say, but the main reason I'm here, or the biggest reason I'm here, is something.
Okay.
So asking them for the biggest problem or the biggest issue is good.
Okay, it's a good tip. And Laura, she has wrote a comment. In primary care, I will make the most of continuity of care and to be able to do lifestyle interventions. Something that works wonders to me is starting with what matters to you and assess the stage of change they may be in. I believe you are going to talk about these stages, Johan. Just let me share one more idea. In some countries, for example, we have here a diabetic and hypertensive patient. In some countries where, for example, with pay-per-performance systems, with health indicators, when a patient such like this comes to a regular appointment, diabetic consultation appointment in primary health care, usually the primary health care team and the family doctor is very concerned to fill all the fields correct so that all the indicators will work at the end. And sometimes this is also very time consuming. So maybe an option, I don't know what you think about this suggestion, would be to make an extra appointment in another day only to talk about behavior, lifestyle interventions, and so on, to be more focused on the patient and in this conversation and in this motivational interview. What do you think about that?
That would be ideal. That would be ideal that to have this. But when it's happening, that I cannot say. But we can, I mean, the patient, it's used that we are typing while she's talking. What I am doing and what is recommending to do, even if it's for 1 or 2 minutes, look in the eyes of the patient. So in that moment, you already establish the connection. And then while you are filling in those things, what are mandatory and you have to do it, you can ask also this, okay, except this something else, what's going on in your life today? So we can do both, but ideally and probably more efficient would be your suggestion. And this is why I think that, of course, the medical doctor can do this, but I think we need also some extra actors in the health system, which could be behavior specialists, for example, who they can help more with prevention, with helping with the implementing the treatment, if that contains or not the lifestyle interventions.
Okay, let's move on. Thank you.
Okay, so when we talk about behavior change, small baby steps. that can be that how much water do you drink per day, or how many fruits or vegetables. And it seems that these small changes are those who are leading in long term on really and sustainable behavior changes. Now was someone probably very, I think, well, that was Laura, who was talking about the stage of change. So it's a pretty old model, which was mostly used as motivation interview as well in addictions, in substance use disorders. So it's coming from the year 70s, was improved. What that means actually, we try to see our patient where is in different chapters, aspects of his lifestyle, how open is for change. You hear Akim. So Akim was talking about something about physical activity, was talking nothing about, for example, sleep. So he was actually related to the sleep. He didn't sleep too much and too well, but he was not interested to do some changes. So when a patient is in such an stage, we say that he's in pre-contemplation. When the patient was about nutrition, so was open, yeah, I know that I'm not eating well, so I would like to know what to do. He's in contemplation. I would like to change something in the next 6 months, but I don't know yet what to do exactly. And here we have often patients who are waiting for us to help. When it's in preparation, the patient, look, like physical activity. In physical activity, he was already doing something. Sometimes in the weekend, he was doing this already for more than a few weeks. I mean, more or less one month. And we can help also here. When someone is in action, there it's already he was already implementing some changes more than 1 month, less than 6 months. So we can correct sometimes, but where we can help changing behavior, it's in contemplation and in preparation. And then we have maintenance and termination, which are for those who are already practicing more than 6 months, their change. So I just found here something which helps to associate, to be for the mnemonic with the word. So pre-contemplation, no change. Maybe if I know how in contemplation, I would like to do a preparation, a plan, and then I'm doing and I keep doing in maintenance. What is very important is that, unfortunately, this is not, once we are at the maintenance, doesn't mean that we cannot relapse to go there. And we know that, for example, COVID had a huge impact on our lifestyle habits. We've been doing physical activity and we just had to stop. We were eating out, we had to stop. Okay, eating out is not the most healthy, but we had some habits which made us to go back maybe in some previous stage of change. Now, what I thought it's also helpful with behavior change is that I always ask, we have to ask the patient in front of us, for what are you ready to change? What you already did change? Which change you did already in your life, and why? Because especially with chronic patients. So with chronic patients, doing already something in your life, doing some changes, it's a gold mine for us to help the patient to change, because that gives a certain level of confidence. And I'm asking, look, you already did some changes. On a scale from 1 to 10, how confident you are today that you can do another change in your lifestyle? Most of the time, if you have a 6, 7 and higher, you can be optimistic that you will have some results. If it's less, you have to dig a bit deeper to see some internal motivation of the patient. Motivation interviewing is one of the most efficient way to change behavior. And it's one of, I would say, maybe next to cognitive behavior therapy or positive psychology or self-determination theory, it's one of the most popular. And it's always about ambivalence. So I would like to change, but I don't have the time. Or look, for the evening, I would like to do lifestyle intervention in my consultation, but I don't have the time. I don't have the opportunity. So this is when we can create an environment to change, and we can use some tools. And Andre was mentioning open-ended question like one of them. The founders of this method, it's Rolnick and Miller, and they are still very active. So they are publishing books, they are translated in many languages. So if you are interested about this method, they are very active on internet as well. So if you are interested about this, I recommend you. And here you see a bit how the founder, they are talking about motivation.
What is motivational interviewing? I mean, it's a way of having a conversation about change. And it's a particular way about having a conversation about change that listens to and calls forth the person's own ideas about whether to do that and why to do it.
One of the fastest ways that you can burn out as a therapist is being convinced that your job is to tell people to change when they're convinced not to. That's a recipe for burnout. And that is, in motivational interviewing, explicitly what you are not doing.
Why don't people change is one hell of a question. It's perhaps a useful question, but there's no single simple answer to it.
One of the things that Steve Rolnick helped me to realize was how normal ambivalence is when you're looking at a change. And to simultaneously want and not want something is perfectly normal.
So now this, when we try to change someone, to facilitate, I would say, we are a facilitator of change, of changing. We have a relational, so how we relate to our patient, and we have also an aspect which is the technical part. And this is not easy. I totally agree. In a very short time to create an environment, a place where the patient feels not judged and where we can be empathic. But I think that empathy, it's not something which we cannot learn. Usually reflecting what the patient is saying or repeating what the patient is saying, thinking at the patient in front of us like an expert and like someone who has to do every day. So I think if we experience in our life taking medication, doing some intervention every day, we can understand what's going on with the patient in front of us. And then this patient in front of us, just the fact that it's there, it's something to be appreciated. So he really wants to change something. He really cares about his health. If not, would not be in front of us. So I'm always very grateful to the patient in front of me for this. And we have some technical tools. We mentioned about the open-ended questions. We have the reflection. We will see then what is it about. And we focus on the change talk. I'm not interested why you don't want to change. I would like to know why I would like you to change. And this, in a very short conversation, we can use two very simple questions. Next to that one, what is your biggest problem today? Why would you like to change? And how? So before we are coming with the advices, which are probably good, probably because we don't know the lifestyle of the patient, ask please this very simple question. And probably will be at the first you have a reaction, what? Yeah, why would you like to change? But really, what motivates you? And then how you imagine this? How would be your life if you would be healthy or healthier? So imagining, visualizing something, it's also helpful. So as you probably realize until now, if you're eventually not familiar with this behavior intervention is that it's very centered on the patient. You are a facilitator. I use, Andre knows that I use a photo there that you have a blind person with a dog. We are the dog. I'm the dog leading the patient. So we're going to the direction where the person wants to arrive, not where we think that the person should arrive. So this is why we try to focus. So focusing on something, it's helping us to have a very determined time consultation. Then we try to dig to find what is the motivation of the person. Because why Akim was doing nothing, or we thought that he's doing nothing with his health. And we just realized there that was a problem with medication. Also, one problem was with the medication because he had a very negative experience and he didn't know, and we know that health literacy, it's an issue with the chronic patients. He didn't know that he can adapt his medication. So I am not judging you. I am just trying to be empathetic with you. And another thing which is very challenging for us is to ask permission to the patient to talk about something. Because we really think that we are gods who can do whatever they think to say, ask, and to go in the life of the person. It's not. It's not. So asking permission, it's facilitating the patient to be there, because we'll be surely a bit surprised that you, the health professional, asking permission. Yeah, I'm asking to you, okay, I don't know if you know about this. I mean, I ask him, do you know something about physical activity? Or because it's a very simple question. If you know, if the person in front of you knows, repeating it, you just lose time. So you are just giving the information what really the patient wants and doesn't know. Or sometimes you can correct also some information.
Yes, and Johan, you can also say in a consultation, for example, if somebody is smoking, you can say, is this a good time to talk about your smoking? And if it's not, and if the patient says, well, actually, no, I've been in the waiting room, my parking ticket is running out, this is not a good time, well, then you're saving yourself time and saving the patient frustration.
Exactly. And it's probably that moment it's in pre-contemplation, so doesn't want to have information for different reasons. It's you lose time. And then
another option is when the patient already says that he already is informed, he already knows something. We can just ask, and would you like to know something more, or is there any additional information you would like me to give you, for example? Because sometimes some patients already consider themselves being aware of everything and knowledgeable.
Yeah,
yes,
indeed.
and sometimes they have made some effort to make a change before.
Mm-hmm.
And
Yes.
maybe continued that change for 3 months, 6 months, maybe longer, and then went back to their old ways, and they feel they failed and they don't really want to talk about it. But there's other ways of bringing that up. So there are many reasons why they might be reluctant to talk.
Yes, but you see, it's when you have this attitude of being non-judgmental. I mean, especially with patients who struggle with losing weight, you can look. Did you do something in the past? Just would you like to share with me? Because sometimes we want to give the same advices which didn't work for that patient in front of us. And again, you gain time when you don't get when you don't give the same information again and again. Of course, it's very difficult for us because we are in a medical field. We want to help. We've been in the training. We are taught that what we learn here in med school, it's what is good, and we have to say to the patient and we have to insist. So this is what the psychologists call a resisting writing reflex. And just a word what the founder of the motivation interviewing is saying about this.
I'd like to address this topic of the writing reflex. which is a term we developed to describe something we noticed outside of motivational interviewing in everyday life. Let's take the example of a mother who's trying to teach a kid to do a puzzle. Using the writing reflex, that mother will simply say, no, don't do this, do that. A problem is seen and the problem is solved for someone else automatically. The problem is that that inhibits the learning of the child to solve the problem for themselves. As therapists and counselors, we can fall into precisely the same trap that that mother did with her good intentions in trying to help a kid solve a puzzle. So faced with a client with multiple problems, given the reasons why we went into the helping professions in the first place, it's just a short step from solving the problem for the person. And that has two effects, which I'm sure you have noticed in your everyday practice. One is, if you like, it taints the relationship between the two of you. It doesn't make for a nice, constructive conversation, and it places a weight on you to solve problems for people, and they tend to shut down. The second can be observed in the behavior of your clients, which is that it doesn't lead to good outcomes. And there's reasonably solid research evidence to support that. This observation about the writing reflex provides one of the clear rationales for motivational interviewing. I'll add just one caveat here. That helpful spirit of yours, the use of that can be channeled into giving someone advice. And skillful advice giving is not the same thing as succumbing to the automatic unconscious use of the writing reflex. And how you give advice skillfully so that it's congruent with motivational interviewing, that's going to be an interesting topic, but it's not the same thing as the writing reflex. I'd like.
So I'm coming a bit back to when to use this. So the ambivalence is something which, and I invite you to look to your patient when you're asking this. If it's saying the word but, I would like to do this, yeah. What happened? You know, I started this, but I started to eat differently, but then I was invited or I went out. Is that the moment when we can jump and say, okay, not why you didn't continue your healthy habits or healthier habits. It's like, okay, so why you decided to eat differently? What you implemented to eat differently? Which are your experiences with eating differently? So we go on in the moment when we hear the word but on the change talk. Empathy, it's very, very important. So, and this usually we can practice it reflecting, repeating or summarizing, but mostly reflecting what our patient is telling in front of us. The motivation interview has, I would say, you have to create an environment, even in a short conversation. We are two experts, you, the health professional, we, the health professional, and the patient in front of us, expert about his lifestyle. I accept you as a person doesn't mean that I accept your lifestyle, but you are a human who, for different reasons, you are struggling with something. So I accept you as a person. So I'm compassionate, and I try to see and to find together, to evoke how you can change. Talking different, imagine that you're talking with a colleague. You don't really, it will be a bit strange to give to your colleague, okay, you should do that or that or that, because we are on the same level of expertise. It's the same type of conversation when we have the lifestyle interventions. And what we try also to do here is to give autonomy, to empower our patients to grow, to be more confident about doing some change. I think about this, we talked also about acceptance, I will not, compassion, as I mentioned it, and then evoking. So the first step is to ask the patient, what motivates you? Why would you like to lose weight? Why for you it's important to have your glycemia under control? Why for you it's important to have your cholesterol in a good limits? So we try to go, I mean, to identify first if it's an external. So I'm here because, yeah, my husband, my wife just sent to me, or I'm here because I'm afraid that I will have the same problems like my father or my mother had. Fear, I'm not a big fan of fear, but especially in men, fear is something which is very internal and it's a motivation to change. Women are more open. They are more, I would say, emotionally intelligent regarding to their health. Men are changing usually when you are, when they are afraid, when they are sick, or when they want to be a role model in the family or in the community. And then finally, which are the skills what we can use to facilitate change through the motivation interviewing? Open-ended question. I think we discussed about that, was also Andrea mentioning it. Then giving compliments. So like was the Akim, I said, look, you must have a really busy time, but you found time with all, driving and so on, you found time to come during the week to your consultation. So it shows that this is important for you. So this is affirmation, the A from the 4 skills. Reflecting, repeating what the patient is saying, and then summarizing. So when we use this type of open-ended questions, and what is your biggest problem today? How would you see that change? What would change in your life? Invites our patient to reflect. It doesn't matter that we cannot use close-ended questions. So, for example, are you interested to talk about was Andrea saying, the tobacco cessation? No, I'm not. Okay, it's very important that you have to stop. So don't ask, why don't you want to talk about this? So, but I would say that 70% we use open-ended question and 30% close-ended question. Now, when we give compliments, please be aware not to be about you. Oh, I find that what you implemented until now, it's very great. I'm very proud of you. I think that you did a good job. No, it's not about you in the conversation. It's not about you, and it's not you who has to change. So what you did, it shows that you are perseverant. Your results show that you are someone really, when decide about something, you are going for it. And then reflections, I think I already discussed that. Reflecting, you can do it very simply. I mean, a simple reflection that, for example, Akim was telling me, sometimes in the weekend, I'm going to run and to bike. So I'm doing the simple reflection would be, okay, so you find time for time in weekend to do sometimes running and to do some physical activity. If you want to make it a bit complex, I would say, look, you really care about your health, so you try to implement some physical activity regularly in your everyday life. Summaries help us to conclude in the end. That shows to the patient that we really understood what was saying. We can also conclude, for example, was the guy who had no time to talk about tobacco. So we can say, look, I understand you are pressed or not interested. I totally respect this. So we don't talk about tobacco. Do you have something else that you would like to talk, which is very important, and you would like to have some questions, some answers from me? Asking permission, focusing on something, and inviting the patient to participate in the consultation. And please focus on change. Always ask why you can ask, for example, so I was a bit challenging Akim, if you remember. So when he said, okay, I can do this in the evening when I'm coming home. And I said, oh, really? No, sorry. When I was in the weekend, I said, what are you doing when it's bad weather? So that is a sustained talk. So it doesn't invite you to change, But it was just one question. I came back again to the change. Why you want to do this? And I let it there to grow in those 20 minutes what we have there. And this is why he came back in the end, suggesting me that, but I can change. I can do some apartment bike exercises there.
Johan,
Please.
Something that we see very often in the real world and that I wish that belonged to the old school. And it's a sort of temptation for us doctors when the patient shows himself, contradictory, when he shows this ambivalence. There is very often the temptation of doing some confrontation, using some confrontation technique to and to show the patient, to reveal this confrontation. What do you think about that?
Confrontation is not motivational interviewing.
Of course.
So, I would say that imagine at the end of our day when we are tired and someone is coming to you with the mirror, look yourself, how you look. So, no, that is not something that help us, no.
And sometimes it even spoils the good work that we have done so far in our motivational interview. When the doctor falls into the temptation of starting confrontation, sometimes it's the end of the we lost the efficacy.
The alliance, the therapeutic alliance. It's the end.
Yes. Because the patient cuts it and
we lose them.
Yes, we lose
the patient, but it's normal. So of course, when I had this patient there and I saw there that even after 6 months, you have the same. And then I was sure, when I started the conversation that we'll say, okay, I had no time to do physical activity. So my mindset about confronting, lecturing, about judging him is there. It's normal. But I'm careful with because you have also a body language, so I'm not rolling my eyes or I'm not, so I was trying, and to be honest, until the 15 minutes, until he came, so I was, okay, he told me, okay, I cannot do it because, I'm tired. In the weekend, it's raining, then I'm not doing it. And then I was a bit I was almost confronting virtually in my mind, okay, you want to do nothing, but you expect different. So, and in that moment came with this spontaneously, but I have an apartment bike home, and that saved the situation. Of course, it's not a miraculous solution. Andre knows that I'm repeating obsessively in the certificate what we did with cases, that people are coming with some miraculous to do some big changes. It's not evidence-based, or at least I don't know about that. But so it's not working for everybody, but most of the patients, and I'm telling now I'm working with soldiers, mostly men, mostly people who you don't tell them what to do outside of their work. So 60-70% of them, talking differently with them, you get results. So that is the percentage which can
We have a question from Jasna Vučak from Croatia. What do you think of using motivational interviewing, and how about CBT? I believe she refers to cognitive behavioral therapy. Which one could be better to be taught in the faculties?
I'm trained just in motivational interviewing, but I would really like to find a good training in cognitive behavior therapy, to be honest. Now, from what I know, it's depends. When we talk about stages of change, cognitive behavior therapy could be useful when something is very, very deep. And for example, I can give you it's mostly related to some trauma, some abuse-related adverse effects later on, or when someone is in an action and that you like to change, to make some. So I'm giving you, it's a soldier, someone who has mostly, especially when they are young, they have a training. So they do physical activity a lot for us who we are normal people regarding this. And then it's coming for different reasons, gain weight, and it's coming, look, I'm trying to eat, I'm eating healthy, I'm doing physical activity, I don't lose weight. What's wrong with me? With physical activity, he's in action phase. But there I have to work on making him to understand that the type of physical activity, what he's doing, maybe is not the best. So, and it's very difficult for someone. So I would say that cognitive behavior therapy are though for very stubborn, very strong personalities. This is how I see today. I could be wrong because I'm not trained. But I can
comment on that. I can comment. CBT is a specific psychotherapy technique, and it requires training and preparation, and requires also an intensive approach to the patient. So there is good, solid evidence that CBT is very effective in treating, for example, anxiety, depression, sleep problems, also some of the eating problems like anorexia, bulimia nervosa, and so on. Anyway, to do this kind of CBT, it requires really preparation, and even the psychologist, not every psychologist has the training that is necessary to do CBT as a program, and it requires an intensive approach. But I believe it's a good thing that we, as family doctors, be aware and knowledgeable about some of the techniques that are used in CBT, because in putting it in simple words, CBT is somehow related with the cognition that a person has of something, of an event, or of a thought, something that comes to our mind. And after this thought or this exposure to an event, usually we assume other thoughts and then a chain of behavior. And the person that is requiring therapy, usually facing these situations, they assume a kind of behavior that is not inadequate and that brings them suffering, for example, anxiety. Okay? So what CBT is the training of the person that in some circumstances, in these events, in these kind of thoughts that the person has, the person can manage to be trained in his mind to find other kinds of thoughts that will produce a different behavioral pattern, a more adequate and adaptive pattern of behavior. So, applying this theory to what we are talking here today, of course, for example, if I want to go on diet and to do physical activity and so on, usually there are some thoughts that divert me because not today because it's cold, so I will not go today outside to run or to walk and so on. So we can work this kind of thoughts with our patient so that he can achieve a different pattern of behavioral. And in this way, CBT could help. But as I mentioned, usually if we talk about CBT as it requires more training and more intensive approaches for the patient.
I think this is why motivational interviewing could be more affordable, easier
for us
to learn in med school.
Yes, more feasible. Yes.
Much more practical, more time efficient as well.
Yes.
Yeah. So my last case, so then Andre still has one. So my last case, okay, I'm again with truck drivers, but I have also other patients. It just happened to be a truck driver again, but was someone who is freshly retired. It's 65 years old, so in Belgium it's still a retirement age, and we don't do protests like in other countries. So he's coming to you for regular medical checking, again related to diabetes type 2. And okay, I'm asking about something new in your treatment or some new medical condition, and a bit about the habits. He shares with me that now, as he has more time, he likes to go out almost every evening with his friends, and where he drinks easily 10, 12 beers. Please be aware that in some cultures, beer is not considered alcohol, but it is. And he smokes 10 cigarettes per evening. He's worried a bit because he gained some weight, and then he has also some decreased libido, some erection problems. And then now he's also worried that you told him that his blood results are not good.
Okay, dear colleagues, we have another televoting question, so please answer. And you are so quiet today. Please make more comments and more questions. We are missing your comments and your questions in the chat. And so, how will you approach him? Telling him to stop drinking, asking him more about his lifestyle habits, exploring more his sexual dysfunctions, checking his medication, and adapting it to his new blood results. So, Johan, the 63%, more than 60% of our colleagues that are attending the webinar, they say asking him more about his lifestyles. Do you want to comment on that? You have to turn your mic on, please.
Yes, sorry. So I see that the percentage are still moving. So I'm trained also like a clinical sexologist, because I think that people, I mean, in life, you can know a lot about people looking how they eat and how they make love. So like a professionist. So I'm happy for this is why I'm happy that 15% of the audience will explore about his sexual dysfunction, because as you probably know, erectile dysfunction can be an early sign of something more serious like a cardiovascular disease. And we know that people with diabetes are at a higher risk with cardiovascular events. But indeed, asking him about about his lifestyle habits would be the best way. And if you allow me, I would even say
yes.
How it went actually. So and I remember him because he was my first case where I applied the motivation interviewing. So this is why I keep in mind. So after I did the training, and to be honest, I didn't know what to do there with him at first sight. So how can you tell someone in Belgium not to drink beer? He will never come back to your consultation. So then, yeah, I asked him, okay, what do you think about your results? And he said, look, I'm worried because I'm really afraid that I will get like my neighbor. I will be like my neighbor. What do you mean? Yeah, my neighbor, he had the diabetes type 2 at my age. He died. Ah, okay. So I asked. So I told him, and yeah, that it's not a very nice experience to lose a friend and to have the same disease. So this kind of empathy, I mean, it's empathy, what I shared with him. And I told him, do you have another reason? Because it was fear, and I don't like to like to work with fear, like a motivation. And he told me, yes, but I have also a nephew, which is 4 years old, and I would really like to spend more time with him in the future. Okay, so from here we went, okay, when you spend time, not in the evening. And then I came with the suggestion, I said, may I tell you something which could be related to your bad results for your diabetes? So he asked me, what exactly? I said, did you know that beer, it's a lot of sugar and that can influence your diabetes results? Oh, I didn't know that. And from here, we went on a discussion in 15 minutes. Again, I didn't have more time, where he told me that, I'm not alcoholic, that I'm drinking 10, 12 beers per evening. Because I can do, for example, he told me I can do what is called Tournée Minérale. So it's something in Belgium that it's a national campaign, usually in February, that people don't drink alcohol. So it's something that it's very proud to do this. So it's a very powerful campaign. And from there, we arrived at he came after talking with him in this environment of acceptance and not judging because he's drinking 10 to 12 beers, telling me, look, but I don't have to go every evening. I can stay one evening with my nephew. I can put him to bed. And then I also suggested him that if you drink one glass of water between 2 beers, your friends will not even judge you and they will not even see that you drink less and you still socialize with them. Because for him, now connection, socializing was important. So that was here the
wow, that's a tip that I've never heard before.
To the water.
To drink, yes. It's a good idea.
Thank you.
It's a 50% reduction.
Exactly. And that's a lot of sugar while he still maintains his social connections, which is also important for his lifestyle.
Okay.
Exactly.
Thank you.
So that was my part, and actually here I had a friend who was a bit overweight on the right and was going to an occupational health checking, and the medical doctor was telling him you should lose weight, and he said you too. So it's how important is actually how lifestyle link us to our patient sometimes, and also us like a self-care, caring about our health are more authentic. So we are talking about something that we experience and sometimes depends by your personality. We can share our own success or not struggling. It's not mandatory, but could help our patients to change behavior. And healthier professionals, they have healthier patients. So according to a study did in Canada. What I invite always to the medical doctors who are in the certificate, and it's to choose during the 8 weeks of the course something that they would like to change in their own lifestyle. And then after 8 weeks, in the end of the course, I have what I call face-to-face, but virtually, a discussion with each of the participants. And then I'm asking how it went. You are smart. I never ask if you succeed to change something. Just tell me about your experience. It's like when you go in a journey, you ask about, asking at the destination, but how was your travel? This is what you ask. And most of the health professionals, they do some changes and they succeed. For those who are not familiar, this is a concept coming from business, where it's your boss imposing you to realize some goals, objectives. But here in a consultation, a lifestyle medicine consultation, you can use it also with your patient. So for example, was Daniel about drinking. So long-term goal will be reducing alcohol consumption. Specific would be reducing beer consumption. Measurable from 10, 12 per day, multiply with 7 was 80, 90. We succeed to arrive to 60. It's not a big step, but it's an important one, and it helps on the long term. So action-oriented, what would be those actions, what you will do to achieve your goal? So drinking the water between 2 beers, maybe not going every day out. Then I'm sometimes when someone is with beer, I said, okay, maybe wine is a bit more healthier if I say this, and so on. So this is when we talk about A. Realistic, what comes in your way not to realize your goal. So for example, here was, yes, I like to socialize. My friends are drinking. So it's very difficult for me to be the one who is not drinking, but I can drink less. So when we find the steps, the actions which doesn't help us to realize something, most of the time we find also the solutions. And how long you would like to try until the next consultation for 1 week, 2 weeks, with help of someone, your family member, friends, colleagues, and how confident you are that you can do today this on the scale from 0, not at all confident, or 10, super confident. For those who got a taste for lifestyle medicine, I invite you on the website, then you can participate in the course. So thank you for this. As we get closer to the sleep time, I changed the blue light with a white light. So I think will be Andre who is continuing from here.
We have here a question from Diana Roda. Is motivational interviewing used in lifestyle changes scientifically proven in elderly patients? And how to deal with predominantly negative patients who seek paternalistic doctors?
There are many questions in one question.
Complex, isn't it?
But important questions.
Yes.
So I will need some help, maybe from Andre or from you, Carlos. So motivation interviewing, it's working in chronic disease, whatever the age it is, because it's coming from substance use disorder, as we know today that it's a chronic disease. Now with the patient, the negative patients, I love negative patients. I love difficult patients because, I mean, it's a big difference with what was a few years ago when I was frustrated about, because these patients invite me to be creative, invite me to ask the questions. And I always give this example. I had once a patient, he was not negative, but he was the guy who helped everybody, not just himself. And then seeing him seventh, eighth time, and he didn't do no changes, no smart, nothing. And then I was fed up, to be honest. I was fed up, and I told him, look, do you have something else in your life that you are just acting like this with changing something in your habits? And he was reflecting a bit, and then he told me, I know I have a house that I didn't finish yet since years. And then he started to talk for 40 minutes, really 40 minutes about his house, what he still needs to do there. But next time, he was the first time in his life when he started to say no to overwork. And then finally, he implemented to do physical activity regularly in his life after 4 weeks. I don't know what happened. I don't have a science to tell you what made the patient to change talking about his house. But the point is that I think that when we have a behavior related to a medical condition or some lifestyle habits, we have the same behavior also in other aspects of our life. Now about that type of medical doctors, and maybe Andre, you have more experience.
Well, medical doctors are human too, Johan. Indeed. So, yes.
The question was about having patients that prefer more
paternalistic approaches.
Yeah, misunderstood. Yeah.
Yes. Again, it's the style. It's like some patients actually verbalize to the doctor, well, you tell me what I should do. Or if you ask them an open-ended question, they say, well, you tell me what it is that I should do about my cholesterol or something. So for people like that, we have to adapt our style, but still continue to explore their stages of change and their goals, and their priorities, and then turn back so that they will take on the goal setting from the point of view of perhaps using the SMART tool or just prioritizing. But there are still people who come in, year after year, if they're looking for an annual lipid check, and the lipids are exactly the same. And if you look back on the records, they've been the same for 7 years, 8 years, no change. And I think of last webinar that we had in Europe, Rev, had a very valid question in terms of, well, how often should we measure the lipids? And the answer for most people was once. So that was very interesting.
Whoa, you watched it.
Yes, I watched it. And I remembered one of the
Great to
points.
know.
A golden nugget, which, how do you manage someone who's looking for paternalistic? Well, if you feel capable of developing that style, maybe if it's going to work for that patient, you can consider changing your style.
I would ask, why do you want me to tell you what to do? I'm just curious. I'm really curious. Why you don't want, that will be judgmental, asking why don't you want to take some initiative? But no, I would ask, why do you prefer that?
Okay.
And let's see what brings.
Interesting. These why questions is always a good strategy in our, and it's a very good tool to use in our clinical communication. Let me just share something about these questions that Diana made about efficacy, or if it is if we have evidence about motivational interviewing in elderly patients. Well, I made a very quick search in PubMed, and yes, Diana, I found some trials and some studies with elderly patients, most of them related to heart failure in patients with heart failure, and some of them, some studies also with high-risk cardiovascular patients, but elderly patients. And in these 2 or 3 trials that I found in PubMed, in motivational interviewing was well accepted by the patients and also effective. So it's not a systematic review, but there is at least some evidence. Okay, Andre, let's move on, please.
Okay, just to finish, I really just thought I would just introduce these 3 points just to close the session, really. Johan, you've gone through all of the setting the scene for helping people with behavior change. So I just thought I'd put in a couple of reflective points, if that's okay. Just on the point of person-centered care, we look at a project that Equip did as part of a Wonka Europe project. It is some time ago. It was 2012 to 2015, and the paper wasn't published until 2018, and I'll tell you why in a moment. But Equip and Europe Rev are 2 of the networks of the Wonka Europe organization in Europe. And these are some of the working groups that were active before COVID, and we're meeting in Dublin in May. And so I'm sure there will be some changes in the groups, but if you look here at person-centered care and sustainable healthcare and professional health, the patient safety group includes the professional health group. I'd just like to talk about those this evening in the context of the European definition of family medicine. And when we look at person-centered care, it's over here, and it includes the doctor-patient relationship. And haven't we been talking about the relationship between the doctor and the patient this evening? Centered on the patient and the context of the patient, promotes patient empowerment for self-management, and has a longitudinal continuity. So we've really embodied person-centered care here this evening. And it was the Swiss College that made this visual representation of I think it's a 33-page document of the domains and the characteristics and the leaves of general practice, family medicine. And this person-centered care project, we involved a systematic review, and that systematic review only found 2 papers, and we searched papers until 2014, I think it was, from the inception of all of those databases, right from the beginning. And we only found 2 randomized controlled trials that looked at what can we educate, or how can we educate primary care doctors and nurses or clinicians that will make a measurable change in the outcome for the patient. So not just an outcome that the healthcare professional was happy to have done the course, or the patient was happy with the consultation, but that the education of the professional resulted in a measurable change in the patient. And those 2 papers, a paper from Germany on chronic back pain and a paper from Denmark on diabetes, both involved motivational interviewing. So we created that course on motivational interviewing. In fact, that's the first paper. And 5 years later, we actually repeated the systematic review. So we printed an updated systematic review, and that paper found 18 papers from quite a few different chronic disease areas, and using a variety of different modalities for behavior change with the patients. But there was a significant dropout from both among the patients and sometimes among the health professionals, sometimes just from the challenge of implementing complex changes, but also from the point of view of time and skills, workload implications, and so on. So it's a very complex area when we're talking about behavior change in patients in general practice. This was just some of the feedback from the motivational interviewing course. We had it translated with one of our colleagues in Germany, Jochen Jensischen. And so there was an English course and a German course, and that was just the findings of the participants. We didn't measure any patient outcomes. So perhaps we'll just finish with this televoting task. Shall I read it, Carlos?
Okay, you may read the case, and then we will see the answers. Yeah, okay?
So I'll just go through it quickly because it will remain on your screen. She's a 47-year-old lady who comes to see you about her menopause symptoms. And she has some blood tests done, and she has a raised total cholesterol of 6.6, predominantly LDLs. She has a sedentary lifestyle, gained 6 kilos in the past 3 years, no family history of cardiovascular disease in first-degree relatives. So you've got 3 choices. You could prescribe a lipid-lowering medication immediately. You could show her online research articles on the dangers of lipids, or you could ask her if she feels she could improve her cholesterol, and if yes, ask her how.
Okay, let's see the answers. So I already shared the invitation to our colleagues. So 93%, 94% answer, ask her if she feels she could improve her cholesterol, and if yes, ask how.
Yes, we have a very motivated group tonight, haven't we? Wonderful.
Yes, we do.
Great. Yes. Yes. And if you consider that response, that takes time. A is the quickest.
Mm-hmm.
C takes time. C takes a lot of time and follow-up. So yes, that's wonderful. Thank you. And I'm not going to read all of this, but we already mentioned in the very beginning the definition of lifestyle medicine and where we can have lifestyle medicine interventions. But some of the areas that we can make some changes in nutrition is not just eating our vegetables and the Mediterranean diet, but actively eating less processed foods at any stage of the week. And less processed foods is less packaging, which is also good for the environment. It also would mean less salt because processed foods are higher in salt. And in terms of active transport, reminding us that active transport is self-propelled transport, walking, running and cycling. And looking at improving our sleep hygiene, it's not simply hours of sleep, it's the amount of the degree of restoration we get from our sleep, and that involves sleep hygiene. Looking at our connections in our family and community and at work, less substance use, and looking at our working lifestyles. That was just to say that I had completed the course with the European Lifestyle Medicine Organization and found it very doable as a busy GP and very practical. So, Carlos, I wonder if we could just ask the participants how they feel they're addressing lifestyle factors in consultations.
Okay,
And
just a minute because I have to activate on my side.
all right.
Okay, colleagues, now we have an open question for you to answer in the televoting platform. And the first one is regarding these two questions. How are you addressing lifestyle factors in your consultations? And what are the obstacles, barriers for you? Let's see if we receive some answers from our colleagues. Just a minute. Because we have always a small delay of streaming. So, colleagues, how are you addressing lifestyle factors in your consultations and what are the obstacles, barriers? Here we have one answer, time.
Right.
By the way, similar to what you presented, greatest obstacle is time. How?
Yes.
Bringing up the issue, asking what people are worried about. Denial, time and incentives.
Incentives, yes, indeed.
It depends on the patient and his her chronic disease. Some people don't have insight of their habits. Motivational interview, time, barriers, time, culturally adequate questions, time. Trying to find out the main bad behavior and consulting on them. Ask about his lifestyle. Time to communicate. Time is the obstacle.
Yes. We're really talking about getting evidence-based brief intervention tools for general practice. Isn't that right? We really need brief interventions that are validated.
We are doing already in substance use behavior, I mean, in substance use disorders. So when we talk about alcohol or illegal drugs use, there, especially in alcohol, you probably know that when you ask your patient, okay, it happened in the last 12 months that you drank more than for women, more than 5 glasses in a same day. And even if one answer it's yeah, even once they happen in the last 12 months, then it's recommended, the guidelines said that you should come with an audit. So it's a more elaborated questionnaire, and then to come with a brief intervention, 5-10 minutes, and medication if it's the case. And then this brief intervention of 5-10 minutes are about motivation interview. What are the pros and cons? What brings you using that substance, so on. So there it's already in practice.
That's where it was. I think that's where motivational interviewing techniques were used first in terms of alcohol,
exactly.
medications, or drugs. Yeah.
Yep.
Okay.
There was a colleague that mentioned the low health literacy on the part of the patients. Do you want to comment on that? And the other colleagues said yes, a
Yes.
lot of immigrants, though there is also a barrier of language.
Yes, I would agree there's a barrier of language, but in our own countries, whatever country that is, health literacy is a very big issue. And it's not just literacy for reading, it's also numeracy and it's digital literacy. There are three aspects to literacy.
Yes.
And it's really, I think any countries where we have chronic disease management programs, where we have a patient goal or a patient development plan, where the patient puts forward their own issues, or let's say, for example, in our practice, where the patients are given a questionnaire to complete while they're sitting in the waiting room. Sometimes people don't complete that for various reasons. Now, it might not always be literacy, it might just be lack of motivation or embarrassment or fear, as Johan was saying earlier on, or a sense maybe that they had tried before and in their mind had failed. So there are many reasons, but literacy really needs to be explored in a very discreet and kind way. Instead of, do you have trouble with reading, you can say something like, would you like some assistance with going through these forms? Or if I recommend a website, would you like any help in accessing the information on the website? And so on. I don't know what you think about that, Carlos. Do you feel that there's this needs to be addressed as well?
I'm sorry, because I was reading the comments of our colleagues.
That's fine. That's fine.
Could you repeat the question?
Yes, I mean, in general practice, we would see a wide range of patients, and all age groups can have literacy issues.
Yes, I agree. Johan, do you want to comment something about this?
Yes, if I may. So to use the time, what is, because we hear so much, yes, the time. So using at maximum the time what we have the patient next or close to us. So in waiting rooms, we can have screens, and there we can present the information the most, for example, in our community, or which are the most frequent, to do some graphics. And today you can, even if you're not a specialist, you can do this, or you can ask someone. Then you can, for example, we had an initiative here, Diabetes Cafe. So you invite patients with chronic disease to get some education session. So then they can socialize, they can talk about this. You have a bit of education thing, and it's very useful and very impactful for those patients with less resources, so they can get social. You have to be careful a bit with the cultural, with in the multicultural societies, there can be some tensions, but except this, they are very, very useful. And then I think that we have to be more on social media. I mean, we as promoters of health, so your medical office, your clinic, where the patients can get evidence-based information. So we have to do education in all the ways which are possible today.
A short comment on that topic about working with patients with less health literacy, and how to try to bridge that gap. I believe the use of visual tools is very useful to explain, so that patients understand easy proportions. When we use visual tools, it's really helpful. And yes, we can also have some tools or either in the web, but we can sometimes also work some of our own writing within plain language, easy to understand, and that would be more appropriate to the kind of patients and the culture of our patients that we have. So sometimes it's difficult to find in the internet specific tools or in a specific language understandable to our patients. So sometimes we have to work our own tools on to this objective.
Our own language, actually, because we tend to use a very complicated, I mean, very normal for us language, a medical language, but studies show that 50% of our patients, they have no idea what we are talking about.
Yes.
It's huge. It's huge.
Andre?
Yes, I think in the interest of time, we might just see if we can see what our participants say about how EQIP and EuroPrev might help them.
Okay, I would invite them to write in the chat. So the ideas, how can EQIP, EuroPrev, Wonka, Europe help you in this field? And then at the end, if I receive some comments, I will share, okay? Because we are running out of time now.
We are. I'll go very quickly through these in terms of planetary health. We had a decision at the Wonka Europe Council last year to collate the views of GP member organizations across Europe towards the inclusion of a new concept of planetary health and sustainable healthcare into the European definition of family medicine. And I firmly believe lifestyle medicine has a very important role in this. There is a carbon footprint of primary care, and you can see the tallest green bar there is an indicator of primary care pharmaceuticals, including GP prescriptions. So we do have a responsibility to address our prescribing patterns in terms of planetary health. I just have an infographic here that the Sustainability Working Group of the Irish College of General Practitioners produced. It's a visual aid, but it focuses on what GPs can do in terms of prescribing and patient care. And you can see under the lifestyle section, 80% of chronic disease is preventable by advising diet and lifestyle factors, addressing, diet and lifestyle factors. And active and social prescribing is another area, and plant-based diets is another area. And we know that the social determinants of health, 40% of our health outcomes are determined by socioeconomic factors, and you can see the range of them there. I'm sure you're all very familiar with that. And social prescribing is a mechanism for linking people with non-medical sources. And it could include, for example, community walking groups and green and blue, use of green and blue spaces for well-being as well. So I don't think we have time for this, but I would like people to just reflect on it because we have gone over time. Have you made a change at work to support the health of the planet?
I believe we may. It's such an interesting question. So, colleagues, have you done already something to improve this topic in your practice? Let me share the screen just a minute. So let's see if we receive any answers. We started using electronic medication prescriptions without paper. Not yet. Giving lifestyle advices and social prescribing for non-clinical conditions.
Excellent.
Okay. So just wait if we receive some more answers.
I would just like to add that when I hear about first time about this concept was Andre introducing it, and I said some new things which has not much importance until I just, it's how much importance has that you hear from right, left. And it's not that I don't trust Andre, I trust that now even more after I saw that it's, you have also two books which are really promoting, and those are two from Harvard. And it's a wonderful concept. So I think the first time was the Lancet, which launched that concept in 2015 or even something like that. But it's really more than okay to sort the plastic and so on. It's really,
Yes.
I really invite you to look for more for this because it's wonderful.
I
Okay,
hope to talk about it in the Europrev conference in April. Yes.
about that, yes. We have here answer lunch walking groups. Huh?
Lovely.
Bring
Lovely.
your own lunch instead of eating out.
Great. Less packaging. Great.
A proper coffee machine instead of capsules. Riding bike to work. Trying to prescribe smaller packages.
Mm.
Cefic created, our Spanish colleagues from the Spanish Society of Family Medicine created a special interest group program to reach all family physicians and help them start helping the health of the planet.
That's true. Quite a number of colleges are doing that now. Cenfic
Yeah.
also and Le CMG.
Okay, powder inhalers.
Yes, and inhaler, changing from meter dose inhalers to dry powder inhalers are one of the low-hanging fruit that we can change. But we'll talk about that another day. But this is just a
Okay.
prompt. It's a prompt.
Okay, thank
Okay,
you.
if I move on?
Yes. Let
So-
me inform our colleagues that I have already shared in the chat the link to do the attendance check for those of you who
Very
want
good.
to receive the certificate. Please don't forget to fill the attendance check form, okay?
And this is just to remind us of the interconnectedness between the health of doctors and healthier patients, and then healthier humans, that's doctors and patients and everyone combined, healthier humans, there's a two-way relationship there with a healthier environment. And this is called the co-benefits of planetary health. And just finally, the science of behavior change in lifestyle medicine can benefit medical doctors too, because oftentimes we need to make an improvement in our lifestyle. And, where does that sit in the European definition? Well, I think it's a human factor. It's one of the human factors that govern the quality of care and perhaps sits down there within science, attitude, and context, and includes our clinical tasks, our communication with patients and members of the management of the GP practice team, and how we manage the practice, including managing our hours of work and our workload. And by behavior change, our health professionals can influence not just our personal health, but also our professional health. We can influence sustainability of healthcare, and that has a knock-on effect and a knock-on benefit on healthcare economics. We can conserve the finite resources in our environment. Even just looking at there's many areas that can be impacted, and that improves quality of care from both of those concepts of quality of care. We have options and can make choices. And this is just a little quotation just to leave us in a little, it's quite late and we've all had a long, busy day. So I have a quotation and an image to leave you with this evening. And Rumi said, yesterday I was clever, so I wanted to change the world. But today I'm wise, so I'm changing myself. And it's late in the evening, and perhaps you've had some time to reflect during this webinar. I hope so. But perhaps you'd like to reflect on the content of this webinar at a future point in time with your colleagues in work. Thank you.
Thank you very much, Andre and Johan. And dear colleagues, I have one more question in the televote. Please answer that question because it's a very important one, okay? And it's not the last one, so don't go away, please. And Andre, I would like to share, because there was still an answer from a colleagues about that questions that we made about what they have done in their practice to improve the health of the planet. And one colleague gave this answer: sharing carnival costumes between colleagues who have kids. It's a funny one.
It's lovely. That's lovely. And done with the best of intentions. Good.
Yes, very, very interesting. Let me check if we have more questions from our colleagues. Okay. No, I have one to you. So we have talked about lifestyle. One of the aspects of lifestyle is stress management. Do you think that going to the movies, to the cinema, can be also a useful tool in stress management as a lifestyle or not?
Why not? Why not? There's an old saying, a change is as good as a rest. It's an old proverb. But yes, because if you go to the movies, you have to get there on time. So it involves some time management. You have to get out of work on time. You're invariably not going to go alone. You'll probably go with somebody that you're connecting with. You might have a healthy snack before or afterwards, or a healthy meal before or afterwards. And watching a good film is creativity. It encourages creativity and the appreciation of creativity. So yes, especially if there's good music.
Andre, you gave a great answer.
Everything all at once. Great. Oh, Avatar.
Okay, this week we had the Oscars. To which film would you give the Oscar? Andre, Johan.
I'm biased because we had a second Oscar from one of the electronic camera technicians from Dublin. He won his second Oscar for being involved in Avatar, and the Banshees of Inisherin came away with nothing, even though they were tipped for nominated for quite a few.
Was it your favorite? The Banshees of Inisherin? It was an Irish film, I believe.
It was, but I actually prefer Avatar.
Avatar. Okay, Johan.
Well, it's there on my list, but let's say that I would like to watch the Fabelmans. So I think Spielberg, he never had a bad movie, so could be even nice to see the movie of his life. So
okay. So I would choose Elvis. I really loved that film, and it would be my choice as the best movie. Well, but our colleagues are so divided,
Yes, they are.
we don't have a win, so it's a tie between the Banshees of Inisherin and Everything Everywhere All at Once.
Very good.
Okay, interesting. Now let me. Dear colleagues, just a minute. Let me invite you to answer a last question in the televote. And meanwhile, I would like to share with you, Johan and Andre, some comments that we are receiving. For example, Maria Bacola, great webinar. Thank you all.
Thank you, Maria.
Okay, colleagues, please, I have already activated a new question in televoting. Please answer. It's helpful for us, okay, to have your feedback on that way. Marisa, great presentation. Thank you for all the sharing. Greetings from Portugal. Mateia Cocotte, great webinar. I'm very pleased that a lot of the presented techniques are already taught to our residents. It's great to know, isn't it?
Indeed.
Yes. Mateja is from Slovenia. It's our Europrev delegate from Slovenia. Gergana Atanasova, greetings from Bulgaria. Thank you for the productive webinar, very useful presentations. Then we had a colleague, Paco Camareles, who shared a paper from the Annals of Family Medicine, a very interesting paper. And we are receiving still more comments. For example, Michelle Anderson, thank you for your excellent work, really interesting and helpful. Congrats. And Rosario Falanga, good night, thank you. Maria Bacola, great webinar. Thank you all. And now let's see the word cloud. Just a minute. I will share the screen so that you can also see it. Are you
I see
seeing
the word motivating there, which is a play on words. The webinar was motivating.
Yes. Educational, inspiring, good, fantastic, interesting, great, exciting, satisfying, awesome. Okay, enlightening. Okay, so, wow, still arriving some answers. So, dear colleagues, it was really nice to be with you tonight. Isabel Cunha also says refreshing concepts and some new clues. Jolita Straujov, it's a difficult name, Jolita, so I will only say Jolita. Thank you very much for sharing your experience and advice. Good luck to you all. Thank you. Marta Tunzeva, very motivation presentation, excellent. So, and one more, Mariana Leitão. Thank you all. Very interesting webinar. Good night. So, Johan, Andre, thank you very, very much in the name of our colleagues that were with us tonight, and there were many, more than 200, I believe, from very different countries. And thank you for all your work preparing these presentations and sharing so many things. It was really, really interesting. And I give you now, each one of you, a final word to say goodbye.
Thank you very much, Carlos. I would like to thank you for inviting Equip to do this webinar with you. And I'd really like to thank Johan for joining us with his expertise. It's always wonderful to hear your golden nuggets and your tips and your advice. And I'd just like to say goodnight to everybody. And perhaps it's a good opportunity to consider making what behavior change could you improve in your own life for your own health and well-being. Good night.
Thank you, and see you in Porto in next April in the Europref conference. Okay.
Yes.
Thank you for everything, and also thank you to the Equip network for this initiative together with us. It was really, really good to have you with us in our webinars. Thank you. Johan?
So I can only thank you for the invitation, and I was very happy that there is interest about lifestyle. So this opportunity and the reactions show us that we will consider differently our patient, and finally that is the most important, that we try here to find ways how we can offer a better care to our patients. So thank you, and have a nice dreams for now. Thank you.
The time passed so fast, didn't it? It was great. Johan, thank you very much. And also thank you to the European Lifestyle Organization to be with us in this webinar. It was really, really great. Thank you. And stay well. Okay?
Thank you.
Thank you. Dear colleagues, thank you for being with us tonight in this webinar. Thank you for your comments, for your questions, for your everything. And I remind you again, I hope I may see you next April in Porto in the Europref forum. So stay well, have a good night, and till next time, until our next